everybody. This is Chris here at Readiness Rewired. And Al, I think it's that time again.
I believe it is, Chris. Time for another healthcare preparedness podcast.
And I think, if I'm not mistaken, we have a guest this week or this episode, and that would be...
Hi, I'm Nicole. I am a regional director for emergency preparedness in the Midwest, kind of on a couple different states, several counties, several different locations. So anything from critical access to hospitals, large hospitals, and clinics.
Awesome.
Welcome, Nicole.
Yeah.
We'd love to have you.
Yeah, great to be here, guys.
And Nicole's one of those people we talk about, guys, that, we were fortunate in our career to wear a primary hat of emergency preparedness. Nicole has a stack of hats that her and I have talked about before. So, Nicole, can you kind of, for the people listening, can you kind of tell all the areas that you're responsible for? Because when you and I have talked before, it's interesting to see the gamut and how things don't really, in my mind, tie together as well, but they're all on your shoulders.
They are. Yeah, I definitely have a mixed bag. So I actually started as a respiratory therapist. So I started about 15 years ago as an RT on the floor, and actually started as a student with the organization I'm with. And they hired me on full time after I passed my boards. So from there, after a few years of, being on extra committees and things like that, I became the supervisor of respiratory therapy. So that is all of your ventilators and patient-facing therapists. So I have a smaller team. I actually ended up expanding that. We took on some clinic spaces. So I have a couple different departments, couple different locations where they run everything from ventilators to blood gas analyzers, pulmonary functions. So lots of different patient-facing activities, along with electrocardiograms. So all of your EKGs and things like that that patient would get. So heart tracings. So I oversee all of that patient facing, and then I also oversee environmental services. So that is all of your hazardous waste and cleaning, and all of that kind of standards and regulations and things like that. And then along the way, I've also added emergency preparedness, which is really my true passion.
So, these single hats that we all wear, if we had to give her all those hats, she'd have hats sticking up this high over her head. And, isn't that the pattern we see across the country? Well, at least this part of the country. If you're not an FTE in strictly emergency preparedness, you have all these other things to worry about. We just highly respect people who can do that.
Yeah, it's a wild ride some days, for sure.
Yeah, Nicole, just to clarify, all those things that you listed, those are within your specific facility, and then emergency preparedness is a regional task that you take on. Is that right?
Yeah, so that kind of came about because, as you guys know, there is a kind of set of people that are really interested in emergency preparedness. All of us sitting around talking today love emergency preparedness, are really dedicated to it. But like you said, there's a lot of organizations that do not have a dedicated person. And so aside from our organization, there was really nobody overseeing those programs. And so, with regulations and everything expanding, really with COVID, we are seeing a lot more emergency preparedness, notice and focus in our surveys and regulatory visits. And then along with the workplace violence. So that's kind of under that environment of care standard, but it really plays a lot into emergency preparedness when you're talking about active shooter and those kind of, threat events. So that's kind of how that So I have boots on the ground in the other organizations, which are phenomenal people to work with. And I just kind of help them make sure that everything's kept up to standards and that we're meeting all the standards and all of our boxes are checked. But that's really not the point of emergency preparedness. So, the emergency preparedness is all about talking to our actual patient-facing colleagues.
So about how much time do you, or what percent of your week is, obviously you've got allocations to lots of different responsibilities. But for emergency preparedness within your own organization and then maybe within the system, can you give us an idea of how much time, maybe in a week or a month, that you allocate to that?
It really kind of depends on the week and the month, truly, what we're doing and what I have on, scheduled. The last couple of days, we had a major incident happen here, and so we had to, put a lot of things into place really quickly. And wearing my RT hats, as well as my emergency preparedness hats, it was the entire week I spent on this one incident. So fully emergency preparedness, essentially. And then at other times, it's probably, 50%. It's not really a standard 40-hour work week ever. That's just kind of the reality of healthcare. So a lot of the emergency preparedness stuff, if I don't get to it during my workday, I will do that education and reading, a lot of research and trending and stuff that we all do to kind of watch the markets and see if there's going to be supply shortages and what's going on in the world. And I do a lot of that stuff outside of work hours. And that's just for my own education. I want to know what I'm doing and be able to do it well.
And I'm sure
Well,
you're compensated handsomely for all that work you do outside of work, right?
Yeah.
Have we talked about this before, guys?
Yeah. Yeah. Well, and I will
Rolling
tell
dough,
you,
for sure.
I will tell you, Nicole, that Chris, when he was working and still as he's retired, Mike and I will get text from him at 10:30, 11 o'clock at night. Ding, ding. Hey, look what I found on this or that. And it's interesting stuff, but Chris is a researcher and a digger and a reader. And then you think, okay, he's a night owl. Oh, no. 6:30 in the morning. Ding, ding. Here comes some more stuff from Chris. And it's like, Chris, let me, I'm retired. Let me rest a little bit, but God love him. So you're doing the same thing in your role.
I read all of them.
To try
I love
to,
it.
yeah, to try to keep up and just keep ahead. And I know I've worked with you on several exercises and things, and you've been a big help because you're very engaged in emergency preparedness, which is really cool to see, because you're right. Some of the people aren't quite as engaged and just want to let the car be in neutral, and hopefully it's rolling down the hill and nothing gets in the way. And that's not always the case, as in the example you were talking about with the incident you spent a week on recovering. And I assume writing after action reports and going through, and now you'll do the follow-up with your committee. Some interesting stuff.
Yeah, definitely. It's there's always something going on, but you're right. I mean, some people just want to check that box, and I think that, maybe 10, 15 years ago that would have been totally fine, but as we see more and more surveyors paying more attention to what we're actually doing and what we're actually having, it doesn't make sense. I mean, this last survey that I had, and we primarily work with Joint Commission and PIA. So I know that's an acronym. But those are regulatory boards.
Yeah.
Yeah. Yeah.
Department of Inspections and Appeals. Yep.
So we want to make sure that we're meeting those standards, and that's really important. But like I said, the most rewarding work is really those face-to-face and those exercises. Those are always fun, and you always learn things. You want to make it as easy as possible for your staff, but then also make sure that there's some things that will definitely trip them up and make sure that they can, really test our system and see what our capabilities are.
So, Nicole, your position's a fairly new one within your healthcare system. Is that right? And can you tell us a little bit about how how is the need identified, and just as you see it growing, where do you see the future of it as, and is it at a director level? Is this at a coordinator level? Kind of just give us a feel for where this position is, where you're at.
Yeah, I think that there is coordinator levels at each location. I do not have a coordinator under me. I kind of just absorbed that position. It is a regional director position. And I was already a director with my other positions. And really it was identified because we had the person that was kind of overseeing emergency preparedness at one of our organizations, and it was one of the larger organizations. She left, and so we had a gap, and we needed somebody to kind of cover and fill in that. And so being all together and working together as a team, I stepped in and kind of helped them out during that time to make sure that they got through. They had a Joint Commission visit within that few months, and you know how critical that is. And so when you can't talk to those standards and be able to answer those survey questions really well, and to be able to, answer back exactly how we're meeting that standard. So I stepped in and did that. And then after that was, I think, in the fall prior to this, so a couple of years ago. And then they came to me and said, hey, would you be willing to maybe oversee all of the programs, just so that we can do further that work, just to make sure we're meeting those standards, but also align all of our organizations and clinics. And I know that a lot of us are kind of working along those lines to try to make things as streamlined as possible. But that's a lot of work to try to align different campuses, because you're talking about different cities, different counties, different states. So it's been a learning curve.
It sounds like to me you screwed up in reverse.
I
So
did.
you should not have stepped up to the plate, and you should not have done such a good job, because then they said, oh, you're now going to do it for everybody. See what happens? When you're too good at what you do?
Isn't that the case all the time?
Dang, girl, you screwed up in reverse.
Yeah, it's all right. It's my passion, so I was like, all right, I can do this. So yeah, and they're a good team. Learning building the facilities was really, really super important. I know that as you get a little bit higher into, having regional positions, some of them aren't at the actual building level, but I'm sure you guys can probably agree. I want to know. I want to know what our HVAC system. I want to know what our redundancy is. I want to know exactly how many, how much oxygen we have, and what our secondary system and how that kicks in, and all of those kind of details, so that I can make sure that we're writing our plans correctly.
Wow. Great job. Great job, great responsibility, and sounds like maybe you have some opportunities to standardize some things between facilities. Do you coordinate anything like HVAs, which are the hazard vulnerability analyses? Some of those things would probably be helpful to some of those facilities in those areas that have vacancies, huh?
Yeah, definitely. Yeah. So when I do our HVAs and even our 96-hour plans and our business continuity, our EOPs, so our emergency operation plans and response, I try to align them. It's really hard. You can get really in the weeds really quickly. So I'm actually working on more of that. I tackled the business continuity first, because those are kind of guidelines for making sure that we have everything in place if we were to have an emergency in our facilities. But the EOP and the actual response plans, those are a little bit more difficult to get, a little bit more standardization, but we're working on it. So we flipped all the plain language. Evidence-based practice is really big in our organization, which is wonderful. And so we want to make sure that anybody walking into our facilities knows exactly how to respond.
I have a question about incident command. And we brought this up with one of our previous guests. So when you have an incident that happens in a given facility, let's say, are you always notified? And then what does incident command look like? Do you kind of leave it to the locals? Let me know if I can do anything. Do you boot up the system-wide? Do you have a system-wide ICS where you can have the mothership support? Like, how does all that look?
Yeah, so we do. So we have system level incident command, so that's already established. And so we have like a crisis notification process. So if there's ever anything, and we kind of have those set guidelines of, hey, if this is happening, if you're initiating incident command, we want to know. So we're part of a very large organization that's throughout the United States. And so we have over 100 hospitals, clinics, long-term care, 100 or more of each in the United States. So we're a very large organization. So we do have the ability, which is wonderful, to pull on all of our system partners and pull them in when and if we need them. They're always there and just a phone call away. But at the local level, we do have all of our primary, secondary, and tertiary incident command members. We try to keep it local individuals. That's not always possible. Like our PIO, so public information officers, those are kind of out of more the central part of the state. So they're usually just a phone call or like an email away. But with Teams, it's really helped a lot. So usually we just hop on a Teams call and we establish when our next update is, and so they'll join those calls. And it's worked out pretty well. We try to do in person if at all possible, because you do miss a few things if you're not. But yeah, it works. We want the people that know the building and know the processes the best to be in those positions. So I have definitely gone to different individuals, key individuals that I've worked with over the years, and said, hey, I really think that you would be a good one for maybe our logistics or planning, or, the people that have been with the organization that might be able to think ahead of time and maybe do some of that pre-planning. I want them in those planning positions. So I'm going to pick somebody who's been here for 20 years. So those kind of things, just kind of pulling those people in and saying, hey, I know FEMA classes are not that fun, but what do you think about this? And I've never had anybody say no. So I've had good buy-in. I have good teams. I have really good people I work with. I'm lucky, and I worked with all of you guys over the years, and I've learned a ton from you guys. Truly, I would not be where I was without the knowledge that I gained from a lot of the other emergency preparedness providers across the state.
So you mentioned teams. That was going to be my next question, but you also answered it. It seems like obviously with COVID, we all had to learn how to do this in the less than ideal way, like you described, face to face. Back when we were all working and meeting together face to face, those are some of the best times I remember, because we built relationships. We knew each other.
Yes.
We had each other's cell phones. We yacked at these meetings. We go have lunch or something like that during the meetings. We got to know people. And emergency management is all about who you know and
Yes,
who
it
you can
is.
get a hold of, right? So when COVID hits, right, then now it's like, okay, now everybody, try to use Zoom or whatever, but it sure seems like Teams has creeped into everybody's world in emergency management, and we're finding that particular platform seems to be, it's malleable. You can change it, you can form it, you can make it whatever you want. And I know my successor had done that in the military and did it, and does it now where I used to work. And it just seems like Teams has been the answer, and it has to be a great tool for you when you're dealing with such multiple agencies or entities under you in under one umbrella.
Yes, definitely. And we figured out, your successor figured out how to connect us on a different, like, you have to just kind of switch it. But I can actually get on a Teams with different organizations. As long as we all have the platform, then we can actually share information even if we're not interagency, which is super helpful. So then I can go on, we can save files in there, or, contact lists and all kinds of things. So I'm excited to use more and more of Teams. There's actually a new version coming out. I was one of the lucky ones that got picked to kind of trial it, and I really like it. There's a lot of really cool features. So technology is wonderful as long as it works well. And that's a caveat to it. So,
See
but
what
you're
you
right.
guys,
In
what
person
you
is best.
what you guys just heard is why Nicole does such a great job. She took on the next level of Teams. It's like, Nicole, you already have your plate full. Let somebody else do that. And oh no, I know Nicole well, and it's like, no, I'll take it on, and then had the technical skills to dig into it, find out what you like, what you don't like. And that's so important. Back to emergency preparedness. That's the whole thing of being a successful and progressive emergency preparedness person, is to be able to dig in, be able to ask the questions, be able to check with your partners, all the things. And so kudos to you, and kudos to a lot of the people who are
Mm-hmm.
still out there that we deal with, because we have a great network that we have set up
We
over the
do.
years, and it's been phenomenal.
Yeah, and a lot of that is because of the work that you guys did to set up that, kind of statewide. Back in the day, it was kind of like, well, I have this name on my badge, so we're not going to play well with, in the sand with that hospital. But that really has gone out the window, especially in the emergency preparedness world, because it really doesn't matter. It doesn't matter what organization you're coming at. And I do get emails from people that I've never really even talked to before, that are said, hey, I hear you're the contact for this organization. Can you help me out with this? And I will send them documents or share with them what I can, to try to help them too, because we all start from somewhere. And so I always appreciated you guys looking over things, and, you guys have all sent me things over the years of, hey, can I see this? So it's always helpful to share that information. And you are 100% right. It is all about who you know. The last couple of days was a really true example of that, in knowing exactly who to contact, what we needed, and having those contacts kind of set up in advance was super easy, because I could just text back and forth and say, hey, we're really in a bind. So, and we did a lot of really good things in a short amount of time, and we were able to make it so we could all take care of our patients and seamlessly. So we really
And
appreciate that
and
coordination.
and there's a key, that what we do is because of the patient. The patient is the important part. And whether we do a lot of emergency preparedness stuff, and I've talked to people before on this and remind them, a lot of it is behind the scenes. No one knows what's going on. We do all the exercises and drills and the prepping and and all the stuff that really, unless you have an incident, you really don't know all the work that's been put in to prepare for, which is the preparedness part of the emergency preparedness. So when it happens, it's not new and strange. It's something that you can deal with. And again, it's all patient safety, it's all patient focused. And I remind people all the time, none of us would have a position or a job, and I don't care what position you talk about, if it wasn't for the patient. So that's where our focus has to be. And yeah, it's so important. And I know you see that. And especially it amazes me with your respiratory background and the focus that you have there with your teams that go in and deal with patient care every day. So
Mhm.
important.
Healthcare is really tough. It has gotten really tough over the last probably 10 years, with all of the changes and rapid, change with COVID. And then, like I mentioned before, workplace violence has really, really increased. And so,
Mm.
our risk factors, and I've been physically assaulted myself. So I know how that is. So leading that work, and it was with a patient who didn't know. It wasn't like it was purposeful, though we do have that, happen in our work environment, but and in the hospital. But people are sick and they're hurting, or they're tired or scared, or whatever the case is. And so, kind of
Yeah.
remembering all of those things that. We just want to protect ourselves, but also protect our patients, because you never want to have those patients, if they're a little bit confused, especially that older generation, they get confused. There's a lot of medical things that can cause a lot of confusion, and they'll kind of come out of that and feel terrible about what
Yeah.
happened, because it really wasn't them. And so, like I said, it's just really all about making sure we're preparing and protecting our people. Healthcare stuff.
Yeah. Great, great statement. And healthcare has changed quite a bit. In fact, Chris and Mike and I have talked. I've leaned on them in the past because they're clinical and I'm not. And that doesn't mean you can't be emergency preparedness. You just need to know who your key partners are. Mine were the clinical people because I had the logistics side pretty solid and locked down, but I needed clinical help, and I know
Hmm.
you and I, Nicole, have reached out and talked a lot. So there isn't a mold that fits a single emergency preparedness person. It's getting in, getting your feet wet, diving in, asking the questions, learning, and doing things so we can all do hopefully a better job.
Yeah, absolutely. I lean very heavily on our facilities. I talked about, our HVAC systems, and so heating and cooling and all of those are answers that I know a little bit, probably enough to be dangerous, but I don't know all the pieces, and so I work with them a lot to kind of understand what our abilities are and what we can do to mitigate risks. So yeah, I rely on them very heavily.
So I'm trying to figure out, Nicole, how do you sleep at night?
Well,
Okay.
not well.
I mean, let's face it, being FTEs in emergency preparedness, the three of us, that's a given, right? But look at all the hats you're wearing. And you throw a pretty heavy clinical component into all of that as well.
Yeah.
I'm not sure how you sleep at night. And, I know COVID was especially tough on you and your
It was.
team because of what you do for a living on the clinical side. And I hate to bring this up, but I know you lost a provider during COVID
I did.
from your team because of getting COVID infected while trying to care for others. That is an immense amount of stress and can really get to you. So how do you do it, man?
Um, I think it's really just truly my dedication and passion. I think that really drives me because it can be any of us. It could be any of us laying on that table. It could be any of our family members. And so that's really important. And you're right. We lost two of my therapists.
Two. Oh,
So
I didn't
one
know
we
that.
actually lost from cancer at the end of October of 2020, and so she passed away unfortunately. And then about 2 weeks later, COVID hit, and I actually got COVID at the same time that my coworker did because we were all working together. And stupidly, we ate lunch together, not even thinking, and we weren't far enough apart. We sat apart, but not enough, and everything was kind of new, and so we all at that table, all four of us got COVID and we're out, which put a huge damper on our team. And yeah, our coworker who had some other background medical issues, unfortunately passed away, and that was extremely, extremely hard on my team. And then I was not even able to be here. I have some immune issues, so I'm immune compromised. So my restrictions, especially then, were pretty high. And I was also pregnant, so I was 5 months pregnant. So scared out of my mind. Scared out of my mind.
Wow.
You talk about,
Jesus.
yeah, sleeping. I didn't. I really just you powered through. Thank God for caffeine. So, but yeah, I was working the front line and then trying to, manage patients. And, there's a lot of political stuff in COVID. And so,
Oh
we want
God.
to avoid all of that. But what it boiled
Don't
down to
even
is
get
that,
me started on the
yeah,
politics thing.
you
I mean,
know,
holy
it
crap.
was rough. It was rough.
Yes.
And it was so, it was really disheartening because we just wanted people to understand that we needed you to do this, to do these things, because you don't know. And just because it's not going to hurt you or kill you, it doesn't mean that it's not going to kill grandma next to you. And, being at the bedside with patient after patient, and I am not exaggerating, that passed away, and watching people suffer during COVID was really, really heartbreaking. And I know that a lot of people left the medical field. A lot of people decided, you know what, I'm retiring. I'm not going to do this, either kind of during it or very shortly after, because it was tough. So yeah, COVID was very life changing, definitely. But thankfully, I got through it, and my baby's fine and no issues. But we definitely did see some adverse effects from COVID and pregnancy, and so yeah, just being scared was a real reality
Jeez.
during that time.
Yeah.
Yeah.
Talking about that and those examples, it brought back, when Mike and Chris and I and Nicole, you and I have talked about, exercises. You come when I was still employed, you came and helped me with an exercise, and you're always planning exercises, and you throw these little injects in that kind of throw a twist and a twist and a twist. And you just brought up the twist there of, being pregnant and this and that. And it's one thing on top of another. And that's where emergency preparedness, it's like, yeah, that's probably our world and then what we have to deal with. And with COVID, I think we can all agree, there's a lot of bad things, but there was some good things that came out of COVID that taught us. Mike and you talked about teams a little bit ago. We would have never been able to do the type of Teams work or Zoom or whatever you want to do because no one would have bought into it as much. Locking down our facilities, which is a
Mm-hmm.
tremendous safety thing. The doctors and others, God bless them, would have never let us do that because they wanted easier access and everybody wanted easier access. But when COVID came, we were able to lock down and stop people from coming in all these 37 doors or 52 doors or whatever the case may be, and focus on flow where you can control. And there was just a lot of good things going on as well that brought us into this new world of healthcare that
Mm-hmm.
15 years ago we didn't even think about. And if we
Yep.
approached locking down buildings or something, we'd have been shot down. But from an emergency preparedness and our security guys and security managers and stuff, now we're all going, gosh, that was a plus. It really was.
Yep, there's always some kind of good that can come out of even tragedy. So, looking at all these events, and it was a terrible thing, and I don't want to live through any more historical events
Yeah.
because we keep doing them, and I think we're still going to see a few in all of our lifetimes. So, it's just, yeah, there's a lot of things. I don't know really any organizations that went back and unlocked doors and things like that because they realized how much more secure and better maybe those changes were. And I think our efficiency with using Teams and using the virtual platforms and having more system access and things like that has really been a huge benefit. So there's always pluses that have come out. And, there was a lot of things that happened. You talk about the heartbreak, but there was a lot of things that happened. Your organization, I'm sure, we got a ton of donations. There was a ton of people that would be dropping off food and trying to take care of healthcare workers, and there was signage and all kinds of things as we drove through town that was, pretty much, no activity in town,
Right.
but there was signage that said, thanks to our, emergency preparedness or, emergency workers and hospital, which was really great to see that. There were some things like our ICU has all big glass windows, and so they put different colored Christmas lights in the windows so that the patients' families could stand outside the windows and wave at their families, and they would know where their families were in the building, which was just one of those things that our staff came up with, and it was a phenomenal idea. And patients' families really like to know where their families were. And that also added, a lot of our organizations used like iPads and things like that, video chatting for our patients. That was never something we would have ever done or gotten that technology in without COVID happening. So we've been able to connect maybe families that wouldn't been able to be here with their family. And so we really tried to take care of our patients, emotional needs too. We're talking
Wow.
about some pretty heavy subjects, guys.
Yeah.
Yeah,
Yeah.
yeah.
But being
Whoa.
able but being able to handle them and move forward and again make something good out of the bad situation. And that's where we need to stay on the positive side and just take a deep breath and move ahead. Yeah, great job.
Well, let's shine the other light or shine light in the dark there too. What Nicole didn't work out well? I mean, what lessons have we not learned maybe from COVID? Were there some things that you're still on your to-do list or challenges that you have to develop workarounds for?
I think that we still struggle a little bit with, things like supply shortages for sure. We're still seeing a lot of those things. And in the respiratory world, that is huge for us. So if you are very aware, Respironics is a very large industry that has
Mm-hmm.
recently had a lot of issues. So anybody who wears a CPAP probably is very aware that there was a lot of recalls and things. And so that directly affects our patients and our access to that equipment. And so really we're we're seeing a lot of changes there with supplies and equipment and things like that. So some of the things that we were using, they've kind of come back and said, well, maybe, we shouldn't have done this, or we should have done this. And it's really not that anybody did anything wrong or that it was really harmful in any way. It was just maybe this worked better than this did, so just learning.
Mm-hmm.
Yeah, I
So,
think
yeah.
one of the big issues we still face is, protecting our healthcare workers for the next go around, right? We had a discussion the other day because I was working with some of my colleagues over with the national groups, and it's like, hey, what do you think's coming next? What are we going to have to be ready for? And that next thing coming down the road, they believe will be another respiratory airborne pathogen, something like a highly pathogenic avian influenza, like H5N1 or some sort of variant of these bird flus that are out there. And that's probably what's going to come down the pike. So that means we face the same issues again. We need to protect our healthcare workers. We need to have enough masking and respiratory protection. By the way, people, masks do work. I don't care what the other crap you're seeing on the media. Masks are very helpful. And trust me, the healthcare workforce knows that. So anyway,
What
stuff
kind of
like that.
masks, Mike? What kind of
You know,
masks?
and that's the thing. Certainly the high filtration N95 respirators, the ones that are 95% effective in filtering certain micron level airborne contaminants out, are the key to the protection of the healthcare worker, right? Those have to be fit tested. They have to be in, good supply. But even some simple surgical
Mm-hmm.
type of masks have been shown to be useful, right, in preventing transmission both to and from. And so, all those sorts of masking supplies are things that I still don't know that we in healthcare have put a good handle on and how we're going to be ready for the next one. Stockpiling's tough. Al knows that.
Mhm.
Yeah.
And, when you have a larger system like what Nicole has, maybe they have centralized warehouses
We
that
do.
they can distribute from to within their own system, where your single healthcare facility that's not part of a big conglomerate doesn't have that kind of
Mhm.
same buying power and ability to store facility equipment and disposable supplies. Those are all things that I don't know that we've all got great solutions for.
Well,
Yeah,
and
we definitely have warehouses as well. Um, yeah, it's tough. It's tough to rotate those supplies and have a good handle on what we're going to need and all of that. And there's been recalls since of different things for different reasons. But yeah, so some of those supplies and masks and things, the
Mhm.
cappers and the pappers, those are the hoods that we put on. Those were phenomenal to have, especially because you didn't have the one thing with those is they're kind of heavy. They're not really heavy, but if you have something on your head for that amount of time, we would get headaches and things like that during COVID because you think you're wearing them from anywhere from 12 plus hours all day long, and so it's that much more weight on your shoulders and head, and then of course stress. You're not stressed at all during those situations, so those were great because at least patients could see our mouths. Because,
Mm.
when you're
Yeah.
hard of hearing, it is really hard for us to talk and to communicate with our patients. And so, at least with cappers, they could see our mouths and they could read our lips. And that would help some of our patients with some of those hearing issues. So,
Just a kind of a, not a detour, but an added note there on these masks that Mike's talking about, those high filtration masks. Those are for particle filters, which are great for biological pathogens. But we see a lot of healthcare workers rushing to those when they're dealing with chemical or vapor responses, and that's not what they're designed for. So it's not only having the supplies, but making sure that people know how to use those supplies in the right circumstances.
Yeah.
That's a
yeah,
good point.
definitely.
There's such a thing as an R95 respirator, and that is more of a protective. It's got activated charcoal built into the fibers, so they can take out a small amount of the type of vapors you're talking about. I used to use it when I did some hydrogen peroxide vaporization work. Instead of wearing a bigger hooded filtration device, sometimes I got away with those types, but you're right. Those are the only ones that could do any kind of vapor filtration. The particles are really the key. And masks do work
Well,
for
Yeah.
and let's
healthcare.
go back for masks. Just even the surgical type masks that everybody got used to wearing after the supply came back in. Um, what was not in the hospitals around the 2021 timeframe? Flu, because everybody was wearing a mask, and so flu rates went way down in hospital patient care because of the mask. Now, and I always said, I'm not proposing that we all wear masks all the time, because that was horrible and we don't want to do that. But masks do work, and it proved that in the time, because we had our hands full in healthcare with dealing with the COVID patients. Luckily, those masks kept the flu patients out of the hospitals, because we didn't have a big thing. And Nicole, being respiratory, you would absolutely see that, from your perspective.
Yeah, we definitely seen an influenza drop, as well as like RSV and a lot of those, even the norovirus. We were not seeing the normal levels of those kind of things that we normally see, which was great, because we didn't have the bed space to take care of a,
Yep.
critically ill influenza patient. And we did see patients that had both that would come in with influenza. So we did still see it, but I think the awareness was so much higher, and I think that it's tapered off a little bit. And I hope that people or just remembered that, standard precautions, which is just washing your hands. Don't touch your eyes or mouth, or, wash your hands before you eat or touch anything, because that is going to protect you a ton. And that really, you don't see that as much. And kids are just little cesspools of germs. And so when you have children and they're touching the cart, and, my son's got his mouth on the cart handle, and, as parents, so I don't know, having that Lysol is always handy. So
I wonder what you think right now, what's going on with measles all of a sudden
yeah,
rearing
yeah,
its ugly head. I bet as a respiratory care professional, when you see stuff like that, you're going, what the hell is going on?
yeah. Mostly like, why?
Why?
Why do we got to
Yes.
handle this? Yeah,
We already
but yeah.
had fixed that.
Yeah,
Mhm.
we
No, the
thought
why
I
is
agree.
vaccination. Yeah, I think we know why.
I don't know about you guys, but I feel like we're going to see more and more emerging. We have climate change, regardless of what, people think. We do have some climate change. And, as things are more unearthed, and maybe, those ice caps and things that are melting and coming down, we're seeing more of those bugs that maybe we don't have immunity to, because they've been, kind of in the past, and now we're bringing them back into our reality. And so if we don't have immunity for those things, and that's exactly what happened with COVID, the coronavirus was around for a very long time, but it was a different pathogen, and so we did not have any immunity, and that's why it hit everybody so hard. And so a lot of people were very confused as to why and how that all happened. But, our immunity is built. And when you talk about the vaccines, and we just did not have herd immunity. So now that a lot of us have had COVID and had that natural immunity, or you've gotten your vaccinations, that's how we have gotten to where we don't have to wear a mask every day. But that we're 4 years later.
Yeah.
So,
and we're still, even with all of that,
Mhm.
people need to understand COVID's still here. Like you
Mhm.
say, it's still here. We've got some immunity built up, but there's still, for some weeks, 1,000 people a week dying thanks to
Yep.
COVID, right? So it's
Still
still,
mutating.
it's
Yep.
still out there. It's still mutating. It's not over, but it's not politically popular for healthcare workers like us to say it's still here.
Yeah. Well, and I have a lot of feedback, and I've gotten a lot of questions, especially from more lay people that are not in healthcare. The misunderstanding of everybody said, well, everybody died during COVID. There's no way that everybody died during COVID or died from COVID. And they did die from COVID. They may have had diabetics were hit very hard. Hispanic community, African Americans were also hit very hard with COVID, it seemed like. And we saw, anybody with a cancer diagnosis or immune compromising, any kind of thing that was already in their system that they couldn't fight off that virus, they would not have died as soon as they did if they had not gotten COVID. And that just kind of not explaining that to people is really frustrating because everybody's like, oh, everybody's dying of COVID. And they kind of misunderstood what we were trying to say is unfortunately, those people did not have to die as soon as they did. They did not have to suffer as soon as they did, and that have that illness. Same with the influenza. We know that influenza does kill immunocompromised in patients every single year, and they might not have passed as soon as if they would not have had that virus. And so that was the whole point of protecting yourself. And grandma or whoever was next to you, because you just don't know. And we've seen a lot of people that were young and that didn't even really have any comorbidities, so pre-existing healthcare conditions. We've seen some patients that still passed away, and that is tragic. I mean, it was awful to watch people that are very young and have young children and families and that didn't make it outside of our doors. So
Hey, Nicole, if we could, we just have a few minutes left. Can we kind of pivot and look ahead? And what is it that is on your on your desktop or your priority list for this year that you're really, it's a priority for you to work on, and you want to maybe let other people know, and if they've got things to share, do so.
Yeah, absolutely. So I have a long list of things that are on my to-do list, but really truly looking at active shooter and active threat. And so we're kind of pivoting from that active shooter verbiage into an active threat because there's a lot of different types of weapons. It's not necessarily only a gun or something like that that is that weapon of choice. And so just kind of pivoting from that. So there was an instance that I am aware of within our general area that happened where a patient had threatened and pulled out a weapon, but he hadn't actually started any action. And so it kind of delayed that response because they weren't sure if that really fit. And so just kind of knowing those kind of things and updating our policies to kind of reflect that. Thankfully, nobody was hurt and nothing happened. But just learning from those events, even though nothing really happened, we want to know exactly, how to prevent those things. So we're working a lot with interagencies. So I work a lot with our emergency preparedness partners in the county. So the EMA. Through multiple counties, and they're always wonderful to work with. And so those organizations, along with our police and fire, we work really, really well side by side with a lot of these organizations to help prepare and protect in case anything were to happen, whether within our own facility or if we were to get those patients. So a lot of work is being put into the workplace violence to kind of prevent it. And then also, the response part of it. And then the other kind of piece that I'm really focusing on this year is kind of just melding those emergency operations plans together a little bit better and kind of putting in what we've learned. So those are my two biggest things this year. Hazmat would be another one. Hazmat is kind of one of those things where it can come from so many different areas. Train derailments, or you have a plane crash, or we have a lot of farmers. This is a farming state. And so just all of those hazards and knowing how to respond. We have a lot of smaller communities in the Midwest. So we have a lot of small fire departments that really just don't have decon and hazmat capabilities. So understanding where these patients are coming from, what their capabilities are, and how they're going to show up at our door is really important.
That is a full full menu. It's an overflowing menu there. You are ambitious, but I'm sure you'll get it done.
I don't think
I
she's
hope
going to
so.
get a whole lot more sleep this year. I mean, I'm not hearing a lot of Z's in your world here coming up over
Yeah.
the next 12 months.
It's just a part-time job.
Yeah, it's just
Well,
part time. Yeah,
Yeah,
part time.
as my old boss used to say, he said, Al, I only expect you to work half days, and it's your choice. You can work 6 in the morning till 6 at night. You can work 8 in the morning till 8 at night. He said, I don't care as long as you just work a half a day. And it sounds like, Nicole, you're working a half a day plus.
Mhm.
So, but great
All right.
great information today. We're excited that you could join us today, and we'll stay in touch.
Just a quick thank you again to Nicole. God, it's good to see your face again. Love to hear your
Yeah.
voice. I miss it. And now we understand why we have such great colleagues like her, that we look at our past and go, kind of miss that stuff as an old retired guy. You know what I mean? Interacting
But
with
it's
great
in good
people like
hands,
her.
right, Mike? It's in good hands.
It's in good hands, but you kind of miss
Trying
it.
big shoes, guys. You guys left big shoe prints.
Just physically, I wear 12s. Other than that,
Yeah.
not the case. So just want to remind everybody, hey, if you like this podcast, make sure you subscribe and ring that bell so you know when we put up another video, and give us a thumbs up if you like us, thumbs down if we suck. But we want to hear from you. And our email, readiness.rewired@gmail.com. Let us know what you think of us. We'd love to hear suggestions, any comments, subjects for the future. We appreciate you joining us.